Welcome back to our series. We're grateful you're here. Before we introduce today's session, you can find our updated programming in a new newsletter on the web. Just Google Greenberg Bladder Cancer Institute. And thanks to Stephanie Cooper Greenberg, we have a recent newsletter full of news from our institute. As we finish out the semester, I wanted to promote a session we are getting off the ground, Office Hours with Noah Hahn, Deputy Director of the Institute. Dr. Hahn, a medical oncologist and bladder cancer expert, will be hosting a Zoom session next Tuesday the 9th at 4 p.m. Eastern. This is an open discussion with Q&A that has proved itself to be very successful, and we look forward to bringing it back with more regularity next semester. Also, keep your eyes on your email for announcements about a new virtual supportive care group for patients with upper tract urothelial cancer, UTUC, led by Kristen Tyree, along with members of our social work team. We're launching this new virtual program this month. Additionally, I wanted to draw your attention to another group of programs specifically tailored around the experiences of women with bladder cancer, developed and led by Drs. Armin Smith and Jeannie Hoffman-Sensis, and a program team of Pamela Getz, Samantha Rockler, and Stephanie Cooper Greenberg. We will be taking a break from programming for the summer from June through August, and we'll be back to you with new programs for September. We're in the process of updating our courses right now. I'm grateful to all of you for joining us today for a conversation with me around our research in precision bladder cancer medicine and the evolution of liquid biopsies. Also looking forward to sharing with you some of the interesting work coming out of our Greenberg lab. Today, I'm going to share some updates and then bring in our Institute co-founder, Stephanie Cooper Greenberg, who is a master of helping us frame these conversations. And then we will have a larger conversation with all of you to answer your questions. So I hope you can all see my screen. So I'm going to start with just a brief update on liquid biopsies. So first, I'd like to just make sure we all understand what a liquid biopsy actually is. And to put it succinctly or simply, it's any test that measures tumor-derived material, biological material. It can be a lot of different things, but we'll be focusing on DNA today in body fluids. And so we can measure these things in blood, we can measure them in urine, we can measure them in cerebral spinal fluid. Our pancreas team measures them in pancreatic juice. There are all kinds of different places you can find body fluids that can contain, in some cases, tumor-derived material. So how are they used? Well, one of the most important ways they're used is to rule in or rule out cancer. So an example of this would be for a patient who comes in with microhematuria. The liquid biopsy can help make a diagnosis of bladder cancer, or can help triage patients so that they don't need to come in for a complete cystoscopic workup, which might be even more important. I should also add that there's work underway here at Hopkins, led by Dr. Bert Vogelstein and others, aimed at developing blood tests that can be used for screening for cancer in patients who are coming in for routine physicals. So in this case, you give it a blood draw, just like you're doing now for CBCs and metabolite measurements for your annual physical. We can imagine a time where the DNA would be sent off for sequencing and other profiling, and that we'd be able to tell not only whether you have cancer, but what kind of cancer it is, and hopefully even where it might be located. Another way that liquid biopsies are used is to detect recurrence, meaning when the cancer comes back. So for patients being treated with BCG, for example, currently what we do is we do a thorough TURBT surgical management. We come in afterward with either BCG or gemcitabine plus docetaxel or some other local therapy, and we do a certain number of treatments. These are all kind of arbitrary. It's not designed on a per patient basis based on the disease going away. We give 6 induction course of DCG and then maintenance, and then after all of that's done, we wait to see if the tumor comes back again. That's recurrence or if it progresses. Liquid biopsies give us the potential to measure this whole thing differently. Liquid biopsy could tell us whether or not the tumor is even there after TURBT, and if it is there and we treat with BCG, whether it's going away. And if it's not going away, we could switch early to a different therapy, say gemdosi, and keep doing this in an attempt to keep the patient's bladder intact. This is also really important and already emerging as a way of measuring metastatic or predicting metastatic recurrence, anticipating metastatic recurrence. So as we'll talk about a lot today, our current clinical tests are not super accurate, imaging, et cetera. They're accurate to a certain extent because they can measure down to a certain size, but these liquid biopsies are much more sensitive. And so as a consequence, we can find tumor DNA in the blood a lot earlier than we can with any other technique at present. And we can come in when disease volume is small, and that by all accounts is the best way to potentially generate a cure. We can track response to therapy. So I just mentioned this in the case of BCG. We can use these measurements to estimate how much cancer is there to begin with, and then we can give a therapy. And if the tumor DNA levels drop, we can conclude that the tumor volume is reduced. This is an important one too. We can actually look at the mutational pattern to find things that we can target with drugs. And the most obvious example of that in bladder cancer is mutant FGF receptor 3. Mutant FGF receptor 3 is the indication for using erdafitinib. So when biopsies are difficult to obtain, or with a lot of patients, the metastatic disease, we don't know if it's the same as it was in the biopsy stage. We can use blood to find this target and confidently match patients to a therapy that will be effective for them. And then there's this thing called minimal residual disease, which we'll talk about more. So minimal residual disease is disease that's there, but we can't see it with our imaging. We have need of this in urothelial cancer, both for local disease, meaning disease that's in the bladder or in the upper urinary tract, and also for metastatic disease. Both cases that might be too small or too difficult to reach by standard approaches, biopsies, and then also can't be measured because it's too small to be seen by conventional imaging. So there's tests that are being developed and they're already available, can see these cancer-associated mutational patterns and even estimate their aggressiveness. And we can assign patients to therapy at a time when disease volume is low, and presumably we have a better chance of success. So again, there's some issues with our current imaging and other diagnostic approaches, and most of you are familiar with these. I'm not really telling you anything you don't already know, but we have limited resolution with our current clinical imaging. We're working with our collaborators here, Marty Pomper's group, to design new PET tracers that can see things at a much higher resolution. Also, we can see biological things like PD-L1 at very high resolution. But still, the imaging approaches that we have that are still in development are not as sensitive as these liquid biopsy tests. So for local disease, we've heard from a lot of you that you don't love cystoscopies. Cystoscopy is still the gold standard, and cystoscopy is still a good way of detecting disease. but it is obviously difficult for the patient. It takes a certain level of skill, and so therefore the test is somewhat subjective. And again, we anticipate, because we've already seen this in some of our preliminary data, that a urine liquid biopsy test is going to be more sensitive than cystoscopy. I anticipate, for now they'll be used in conjunction with each other. But we can anticipate a time when you might even imagine cystoscopies will come after a liquid biopsy test to locate the tumor for resection. And then for metastatic disease, we with conventional imaging techniques, we get about a resolution of about quarter of an inch, but a quarter of an inch can contain billions of tumor cells. And we'd like to get in there as early as possible with our systemic therapies, so we give our patients the best chance for cure. So we're going to be talking today about DNA-based liquid biopsies. And what DNA-based liquid biopsies measure are the specific mutations that are present in cancer that are not present in normal cells. And so there are two ways that we have of doing this. One way is that a company called Natera and other companies take a piece of the original biopsy. They do sequencing on that biopsy. They find the specific mutations that are present in that tumor, and they design a super sensitive test to measure those mutations. So this is truly a personalized test. The other way that we do this, and this is actually the way we're doing it mostly, is we develop a panel of mutations that are commonly mutated in bladder cancer. And then we don't need to sequence the primary tumor. We don't even need to find it. But we use that panel of mutated genes on either blood or urine, and we sequence really deeply, meaning very, very sensitive sequencing. And by doing this, one of the advantages is that if the tumor evolves in some way, either because we're treating it with something that's causing it to change, or just because of its natural evolution, we will still find it. Whereas there's a chance with the tumor-informed test that the cancer that's most important is not the cancer we sequenced in the first place, and we may not be able to find it with a tumor-informed test. The advantage of the tumor-informed test is it does tend to be a little bit more sensitive than the panel tests, but there's strengths and weaknesses, as you can see with each approach. So what are the potential clinical impacts for us? Well, we want to directly measure the impact of our intravesical therapies, whether it's BCG, gemdosi, or some other investigational agent. And again, the idea here is that we'll find some tumor data to begin with. And if the amount of tumor DNA decreases in response to our therapy, then we will know that the therapy is working and the tumor cells are dying. We also want to confirm later that therapy has eliminated all the cancer. And the reason we want to do this is that we want to provide patients with bladder and or upper tract preservation, renal preservation. And so we really want to confirm that all the cancer is gone so that we can go forward with confidence. It doesn't mean we would stop measuring tumor DNA in this context. We would still continue to measure in the surveillance setting, just like patients are going in now for cystoscopies after definitive therapy. But in this case, we would be looking for also some changes in the tumor that might cause us to change our therapy. We want to identify these mutations that might help us select therapy. And then finally, we want to be able to select patients for adjuvant therapy. Right now, it's adjuvant immunotherapy, but any adjuvant therapy. What this means is that after we, for example, do trimodal radiation, chemoradiation therapy, or we do cystectomy, we don't know if the patient has low levels of metastatic disease that should be offered treatment with some other therapy to get rid of it. And so using plasma measurements, blood measurements of tumor DNA, we think we'll have a better way to identify patients who actually need additional therapy beyond surgery. So I'll give you a little bit of more information about that. So it's one of the hottest areas in our field right now. So recently, you probably noticed that nivolumab, which is one of the immunotherapies that we use in bladder cancer, received FDA approval for treatment of patients, all patients, after cystectomy. So that approval has been very important, and there's a significant survival benefit provided. However, what was strange was that a very, very similar drug, atezolizumab, the clinical trial that evaluated that drug in the same setting was negative. But later work involving liquid biopsies helped us understand the reason for that. And what that work showed us was that atezolizumab only worked in patients whose blood contained tumor DNA. So here are the results of the nivolumab work. You can see that there's a significant increase in survival in unselected patients and also in patients who had high levels of PD-L1. But in the atezolizumab trial, the trial was negative. And this was very confusing because these drugs, as you know, are considered relatively equivalent. Might have had to do with the patient populations being evaluated. Anyway, in an additional study that was led by our colleague Tom Powles in the UK, the investigators separated patients into groups based on whether they did or did not have tumor DNA in their blood. So if they did not have tumor DNA in their blood, at the time of therapy, they probably did not have much, if any, metastatic disease. So patients receiving therapy under that circumstance, because they don't have any metastatic disease, probably would not be expected to benefit from the therapy. Whereas patients who do have tumor DNA in their blood, and again, remember, these are patients who are clinically free of metastatic disease by imaging, they would be the ones, because they do have some metastatic disease, who should receive the most benefit. And sure enough, if you compare the light blue and the light red graphs up here, these are the patients who did not have any tumor DNA in their blood. You can see they're right next to each other, right overlying each other. Whereas down here, you can see the red curve are people who had tumor DNA in their blood and did not get the drug. They did much worse than people who did have tumor DNA in their blood and did get the drug. And so, what this indicates, both in disease-free survival and overall survival, is that the benefit of atezolizumab in this study was limited to patients who had positive liquid biopsies. We're also in bladder cancer fortunate to have the ability to measure the amount and the biological properties of the cancer that's growing in the bladder. So the tests I've just described, the liquid biopsies on blood, tend to measure metastatic disease and perhaps locally invasive disease. But for us, we're also treating a lot more patients with local disease in their bladder for bladder preservation purposes and other purposes. So there's been a very, very strong effort by our team and others to develop liquid biopsy for urine. And what we can now do with this liquid biopsy is we can actually use it to kind of estimate stage and grade of cancer. We can track the effects of surgery and intravesical therapies by watching how the levels of these tumor DNA patterns change. And we can, similarly, we can confirm that neoadjuvant pre-surgical chemotherapy or pre-surgical immunotherapy or whatever it is that we're trying to use to eliminate cancer in the bladder, as well as any systemic disease potentially. We can confirm using these liquid biopsies that we not only eliminated the systemic disease, but also we eliminated the disease in the bladder. And so ultimately, we can see a time where a negative liquid biopsy in urine would indicate a role for organ preservation. So you've probably heard of the RETAIN trial. This is led by our colleague Betsy Klimek at Fox Chase, where patients were assigned to different treatment options based on whether or not their tumor had biomarker in the biopsy and then clinical staging afterward. And if the biomarker was positive in the biopsy and the clinical staging was negative for cancer, they went on active surveillance. This trial was pretty successful. but it wasn't perfect. So the biomarker in this case, called a DNA damage repair mutation, you can see the specific mutations that they measured down here. We predicted this would be 100% successful at identifying tumors that would be sensitive to cisplatin-based chemotherapy. Unfortunately, it wasn't. Some of the patients in the active surveillance arm recurred. 10 of the 24 had to go on to cystectomy. And it's an indication that our biomarkers that we trained on biopsies aren't enough to assign patients to therapy with 100% confidence. So if we had included, and the group at Fox Chase is actually doing this work now, but if we included a urine liquid biopsy after neoadjuvant chemotherapy and aggressive TURBT, we might have picked out these patients who were biomarker positive, but still tumor DNA positive, and assigned them to either a different bladder sparing approach or potentially offered them cystectomy. So we've been working in the GBCI more on using tumor DNA in urine to track the effects of our intravesical therapies. So this is an example of a cohort of 33 patients who all got thorough TURBT. And this graph shows total mutation count, different types of mutations here. You don't have to worry about them. But what you can see from this graph, what I really wanted to point out is that after TURBT, some patients have very low levels of any tumor DNA. They may already be rendered free of disease by surgery, whereas others over here have much higher levels that indicate the need for intravesical therapy. So we've trained our biomarkers to see all of these patients the same way. And as a result, it's been very difficult to find biomarkers that predict response to BCG. But we imagine now, by being able to separate out the effects of surgery and therapy, that our biomarkers are going to perform much, much better. And what's really fascinating, and I still think this might be one of the most provocative things I've seen, there are very similar data coming out in advanced disease setting, is that if you look at the pre-BCG level of tumor DNA, which is measured here, those patients who had none are up here, and those patients who had some are here. Already with this pre-treatment biopsy, liquid biopsy, you can already predict who's going to probably do well and who's probably not going to do well. So overall, it may be that the volume of disease that's present in the bladder, as indicated in this graph here, these patients were recurrence and these patients were not. These are high risk, these are low risk. The volume of disease in the beginning may be a more important determinant of outcome than even the intensity of BCG. It's a provocative observation that we hope to follow up with in additional studies. So with that, I'm going to stop talking and open it up to questions and answers with Stephanie.
Here I come.
Super.
David, thank you for that. It's super hopeful. You know, this is a really weird. Hi, everybody. I'm here to sort of unpack a little bit of what our beloved Dr. McConkey said. Let me try and start my video. I think, Wasim, if you could put me on, that'd be great. You know, one thing that I never have really even occurred to me, but if you're going to have bladder cancer, which is awful, one thing that is a benefit is that urine, you know, you can really access the bladder and you can really see what's going on. And urine is plentiful. We all have lots of it. It's not like closed system in the body where you have to like puncture or, you know, whatever. So I think that's sort of an odd thing to be grateful for. And I have lots of questions for you. So please forgive how, you know, one-on-one they are. But I think this is a clearly a thrilling new field, and I have a provocative question for you. But let's back up. When you have urine cytology, you go to your urologist, you want a urine sample. What currently are they measuring? And is Is that any like,
Mhm.
that's a Quest lab thing? Are they measuring blood in the urine, or what are they looking at when it's a normal being done every single day in clinics? What is that?
Right. So urine cytology is looking at cells in the urine. And it's looking at cells in the urine by a pathologist. So a pathologist, just like a pathologist looks at a section of your tumor and tells you if it's high grade or low grade, invading the lamina propria, invading the muscularis, creating a stage. The pathologist in this case is looking at the way the cells look and how abnormal they look compared to normal urothelial cells. It's kind of a subjective technique. We can imagine a time where you've all heard about machine learning. I think as we start to scan a lot of these images and ask computers to recognize features, they could become a little bit more standardized. But so far, cytology has proven to be really important when it's positive for high-grade cancer, but not so helpful when it's negative.
So when a pathologist is reading the urine cells, are they in general say, oh, that's a UTI or that's a bladder cancer cell? Does the machine screen for that, or does the
The
pathologist have to know
pathologist
what they're
has to know
looking
what
for?
they're looking for.
Okay.
And
That's
there's a lot of uncertainty.
Yeah.
Even some of the labels that they use to describe the cells indicate that uncertainty. So
next question. There
Mhm.
are some biomarkers on the market, urine biomarker, and I'll mention a few. There's
Sure.
immunocyst, CX Bladder, Assure MDX, and Expert BC,
Mhm.
among a few of the samplings that I Googled about current urine cytology, maybe specific to bladder cancer. Are those effective? And is what you're talking about just a completely is this, but like completely more sophisticated?
Yes. So what we're talking about today is much more sophisticated. But that's not to say that these other tests, and maybe in particular CX Bladder, look promising. Eurovision fish, which a lot of people have heard about, is measuring chromosomes. And so it's still looking at the urine sediment for abnormal cells that have abnormal chromosomes. Some of these other tests do the same thing with immunohistochemistry. They use conventional pathologic approaches using novel markers to determine whether this sediment that we have, that the doctors using, pathologists are using for cytology, looks like it contains bladder cancer cells. What we're talking about here is a totally different approach. For one thing, we're taking DNA out of urine, usually whether it's soluble, whether it's floating around, or whether it's inside a cell. So we're sampling all of the available material in the bladder. It's not like we're taking the cells out and looking at them. A lot of the tumor DNA, in fact, many people think most of it is just swimming around in the urine. It's come out of the cells and it's
being
floating around.
shed by the cells then. They're
Correct.
like dust
Correct.
particles.
Yeah, and it's
Okay.
the same in the blood. We've started to have some understanding about what makes a tumor cell, a big shredder, a big shedder. And one of the things that makes a tumor cell a high level shedder is being clinically aggressive. So the other, I guess, convenient thing about these tests is that they're especially good at measuring clinically significant disease. But with that said, the urine tests that we use now in the urine are capable of detecting low-grade disease too, and telling us that it's low-grade disease just based on the mutations that we see.
Is there a great advantage the fact that bladder cancer starts in the epithelial lining of the bladder and there's urine touching the?
Yes.
So is that something we should all be happy about
Well,
it.
yes. So one
Compared
thing
to other awful cancers who don't have urine
yeah,
as a.
yeah. It's true that people are looking for this in patients for prediction of prostate cancer and kidney cancer. Uh, but for whatever reason, it hasn't worked well for them yet. Kidney cancers don't shed that much, unfortunately. So that may be
Different
part of the
cancers
reason.
shed differently. Okay.
Correct. Yeah. Prostate cancer, we know there are some prostate epithelial cells that some people find in the urine. My feeling is that tests will come for prostate cancer, but so far the bladder cancer detection is much more sensitive than these other cancers that are in the genitourinary tract. So yeah, it's actually really unbelievably lucky that we have tests that seem to separately be more sensitive for either disease in the bladder or disease outside the bladder. So we can use both of them together to decide where we need to treat the patient, whether it's more local therapy in the bladder, neoadjuvant chemotherapy, radiotherapy, or we need to go with something systemic to get rid of the metastatic.
So I have two giant questions. These are like the big picture questions. So the ideal biomarker, call it urine for this conversation, could be blood. Do you see a day, and don't be Mr. Pollyanna here, because you're a scientist and you really know how long these things take. Do you see a day when the ideal biomarker would be, I have to read my notes here, it's cost effective and covered by insurance. It's not some astronomically expensive test. It's fast and easy for the patient. Everyone can give a urine sample. That's not too hard or invasive. It's easy to interpret. You may be at, a little lovely local community hospital or urology practice in the middle of nowhere. I live in the middle of nowhere, so that's not pejorative, but like everyone understands what they're seeing, and you don't have to go to Johns Hopkins to have it read, where it has high sensitivity for low-grade disease and actually tells you something meaningful. Do you see a day, Dave McConkey, I'm putting you way on the spot, that
Yes,
this could
I
be
do.
possible?
So we're working closely with one of the companies that's developing these tests. The company is called Convergent Genomics, and they have a test called UroAmp that's already clinically available. We know urologists who are using it right now. I don't know if they're using it and getting insurance reimbursement, or whether the company itself is paying for some of these tests, but their test can do just that. The data I shared with you were collaborative data we generated with them. So point is, we want something that's clinically available and sensitive, specific, can tell you whether disease is high risk or low risk, and democratic, right? So we want anybody anywhere to be able to get one of these evaluations done and have it be just as accurate as anybody getting it anywhere else. And so Convergent has a preservative that they've developed that allows urine to be collected and sent to them at room temperature, stable for weeks. So patients could do this at home eventually. Patients could do it at home, bring it into their doctors, their urologists, maybe even bring it into a satellite place like Quest and have it shipped from there. But this would be a very routine diagnostic procedure, whereas cystoscopies, as we know, are more difficult for patients, and also, frankly, a bit more difficult for urologists. We've got really great cystoscopy at high volume centers like Hopkins, but the performance is uneven and certainly not as good at low volume centers and community hospitals and so forth.
My next question is a big one. So
Sure.
If and when, let's go with when these tests are readily available and accurate and democratic, as you say, do you see a day, maybe for patients who may be at risk, or just as a general screening tool? We have mammograms, we have PSA tests, there's spiral CT for lung cancer, preventive testing. Do you see a day where this biomarker test that's perfected by many and is available could be used as a screening tool for bladder cancer, period.
Yes,
It's just urine.
yes,
And we all produce, like it or not, that's part of life.
yeah,
And wouldn't that be amazing? And
yeah,
can't imagine what an impact that would be, because the problem with bladder cancer is most people don't know they have it until they have it. And then all hell breaks loose, right?
yes.
So,
I think that's definitely possible.
and now to shift, and we have 9 questions, so I'm going to shut up. Is the same about the same robustness of discovery research going on, the same for blood
Yes,
biomarkers as well?
it's even beyond this. Yeah, yeah. So for blood, there are lots of companies in this space developing much more sensitive tests. And there are clinical trials open right now to confirm the results I just shared with everyone, which were that only the patients who have tumor DNA after surgery, after cystectomy, really benefit from adjuvant immunotherapy. So the data I shared with you was kind of an add-on to the IMvigor010 trial. Investigators are now enrolling patients prospectively to assign them to get immunotherapy only if they have tumor DNA present, and they're going to compare the outcomes of patients who are assigned this way versus those who aren't. So I think that the blood liquid biopsy impact is going to happen even faster.
Wow. And again, it's shedding tumor in the blood, and
Yes.
it's run through a machine that detects it. Is that kind of how it works?
Yeah, we've got these tubes we call Streck tubes, and
Yeah.
we process the blood using these Streck tubes, and we take the plasma that we get and we isolate the DNA, and then we sequence it. And there are, again, these kind of designer tests that are offered by Natera. Their test is called Signatera. They'll ask you for a biopsy of some kind, and they'll do deep whole exome, whole genome sequencing on it, and then they'll design a custom assay just for you. And then they'll use your blood and your custom assay to track the presence or absence of cancer. And this right now for bladder cancer patients is the gold standard. It's been used most high-profile studies. It's the one that was used in the Tom Powell's Nature paper that I shared today. So that probably is kind of the industry standard at this point, although there are tons of other companies in the space.
Before I go to the 10 questions, what you're just talking about, is that something that you can get in the clinic or ask for or not?
Yes.
And
Yeah.
so say, I want the Natera test to see my tumor DNA. I want to know what's in there. And it could be quite revealing, right? I mean, does insurance pay for this, or?
It depends. So if you have metastatic disease, we often see cases now where there's a discrepancy between the tumor biopsy and what's in the blood. And so measuring the blood is important because we want to see if there's an FGF receptor mutation in there, so we know whether or not to offer a patient erdafitinib. So thanks to the approval of erdafitinib, we now have access to insurance coverage for these liquid biopsy tests. The indication is to find FGFR3 mutations, but of course, they find a lot more than that. Dr. Han here is a little concerned about turnaround time, and so he's trying a whole bunch of different liquid biopsy assays. And frankly, it may be that many of them work just fine. It may not need the Natera assay, this designer custom assay. It may be that a panel assay is just fine. So Tempus has one, Caris has one, Memorial Sloan Kettering has one called MSK Access. We have our own. I think what you're going to find is that more and more studies will compare them head to head. As of right now, I don't think there's really any reason for why Natera needs to be more robust and sensitive than some of the others. They're all very good.
But the takeaway is for metastatic disease,
it's available.
It's available and ask for it. Okay, super. Okay, questions. Our beloved Katie Hahn. Hi, Katie. This is a question. Your answer. You have to answer. Can liquid biopsies be used in the case of recurrent suspicious urine cytology readings over 3 years? And what is the accuracy of
Right.
liquid biopsies?
So, Katie, to answer your question, we don't have enough experience with the performance of liquid biopsies for me to give you a really hard number here. But the sensitivity and specificity look like they're around 90%. Not only for the detection of cancer, but for the discrimination between high risk and low risk disease. Now, there's no FDA approval for a urine liquid biopsy test. So there is a CLIA test available, and I think another company called Predison is another company that's developing a test that looks like it is or will be clinically available soon. Our collaborator, Roger Lee, uses this a lot. But as of right now, even though it looks like these tests are definitely strongly helping in the setting of surveillance, meaning that somebody who's already been diagnosed with cancer is coming back for routine cystoscopies to see if it comes back, these tests look like they perform at least as well as we would want them to, and probably just as well as cystoscopy, if not better. So there'll be a lot more research on this. So right now, to give you a sense of what we're doing, so we took all of the samples from the phase 2 clinical trial of adstiladrin, nadofaragene, and we sent them off for sequencing to correlate the positive values with outcomes in that trial. We did that with Peter Black's atezolizumab trial called S1605. We're looking into doing that for the S1602, the PRIME trial. We want to really take this out for a test drive in a lot more patients, but I do expect that there will be indications for the use of this test that are covered by insurance in the not too distant future. And for now, I've asked our friends at Convergent how much this test would cost. They don't imagine it's going to be that expensive. So it may be that some people will be willing to pay for this out of pocket.
Okay. I hope that helped, Katie. Mr. Singer asks, are liquid biopsies available outside of Hopkins? And can I get a liquid biopsy at my local medical center? Great
Yes.
question.
So they are available outside of Hopkins. They're all either academic or commercial. So a local hospital would not have its own liquid biopsy, but it probably would have the ability to send off blood for one of these blood tests to a company like Foundation Medicine or Caris or Tempus. For urine, as we were just discussing, there is a CLIA-approved test that's offered by Convergent. It's undergoing analysis now in a lot of different contexts, but that test is not available yet. I hope it's available soon. We've been waiting a long time for this. A lot of us have been very optimistic about how this would work, and it looks like our optimism has so far been confirmed. But right now, still, we've got AUA guidelines in place, and urine liquid biopsies are not even mentioned. So we're gonna have to wait for guidelines to change for us to introduce them into our patients.
Do you see a day when the AUA guidelines, which are like sort of present sort of the standards of care for bladder cancer, a lot of thought goes into them. Do you see a day when liquid biopsy will be part of their guidelines? And is there a push to do that right now? You were just at the AUA in Chicago.
I was just the AUA, yeah. So I think that what we're going to see is an evolution over time. I don't think the guidelines are going to change soon. And the reason for that is that cystoscopy is still very, very effective at surveilling patients for bladder cancer. And so urologists are understandably very cautious about, for example, thinking about doing less frequent cystoscopies and more frequent liquid biopsies. So fortunately, the urologists, including Nurse Singla in our own group, are the ones who are evaluating these technologies themselves. And coming back from AUA, a lot of the meeting was about liquid biopsies. And I can tell you our leadership, our urology leadership nationally is very enthusiastic about these.
Great. David, we have to satisfy Mr. Singer and go back to him. Beautiful question. So at his local medical center, probably not.
No.
But he should ask for one of these more sophisticated biomarker urine tests, or should he also get a second opinion? This is my question, at an academic medical center. And would that be helpful to him? And also, anyone listening, if you have a question, you can always email it to us and we'll answer it like intelligently, like written down with the names of these companies. It's astonishing that there are so many now. There used to be none 10 years ago. So bladdercancer@jhmi.edu. Please, if you want specific answers or this will be recorded too, by the way, we will absolutely reply with the right answer. But what do you suggest?
Mr. Singer?
For Mr.
So
Singer?
Mr. Singer, the urine tests that are currently available and used by urologists are some of the ones that Stephanie mentioned earlier: Eurovision, BTA stat, NMP22. There are a bunch of them that urologists have had for a while. My own feeling is that the CX bladder tests looks particularly interesting among these tests that have been around for a little bit longer. It still only measures a handful of things, but it looks like it's pretty good. So you could ask your urologist if you're interested in something for the disease in the bladder. You could ask your urologist about one of these tests and whether it would be beneficial to augment the information gained by cystoscopy. For the blood, if you're dealing with metastatic disease, or you've had cystectomy and you're thinking about next steps if you have to, for blood, you can get these tests done. My feeling is anywhere. You just have to ask your doctor to either order it themselves or come to an academic medical center for a second opinion, and we'll order it for you here. So there has to be an indication for it to be covered by insurance, as we said earlier. So these would be patients who've already received platinum-based chemotherapy or are ineligible for platinum-based chemotherapy and had definitive surgery, cystectomy. And then if there's some concern about disease coming back, you can get this paid for by insurance.
And specifically, he asked for a liquid
Blood
biopsy
test.
blood
Yeah.
test.
Yeah.
Test from like Foundation, or that's the
Right.
name of Foundation Medicine and the other
Foundation, Tempus, Caris.
Tempest, TEMP,
Yeah.
CARIS.
Yeah. Gardent is
I
another
hope-
one.
I hope that helps. You can always email us, and we're here for the to help guide you. So Dr. McConkey, on your last slide, did you mean, I'm just reading directly, the original volume of disease or the volume of disease remaining after BCG predicts
The
reoccurrence?
original
So
volume disease. So we're measuring disease here after TURBT. So many of us, including myself, have wondered just how much impact surgery versus BCG have on preventing recurrence. And I think that it's still early days, but I think these data suggest that the impact of surgery may be a lot higher than has been appreciated. And I wonder if the same isn't true for TMT, trimodal therapy with radiation. And it's also possible the same is true for patients who come with clinical T2 disease, get neoadjuvant chemotherapy. Our surgeons are oftentimes doing very thorough TURBTs before the chemotherapy. And so measuring the impact of that surgery is another opportunity for us with this liquid biopsy.
fascinating. Ms. Churchman asks, are the genomic profiles of non-muscle invasive bladder cancer and muscle invasive bladder cancer different?
They are, but not obviously enough for us to be able to distinguish them just by looking at genes. So Convergent has used AI and machine learning, and they also use another technique they call low-pass whole genome sequencing, which tells us about chromosome level problems. to develop an algorithm that stratifies patients into high risk and low risk. This is sort of analogous to non-muscle invasive and muscle invasive, but it's trained at this point on recurrence. I think that similar kinds of approaches could be used to detect muscle invasion, but those haven't, as far as I know, been developed yet.
So she also asked, in other words, is non-muscle invasive disease and muscle invasive disease, are they two different diseases, or does one non-muscle progress to muscle and it's the same disease?
We're still studying that together with some colleagues at Columbia through a project that's supported by the Mark Foundation. But I think that there are two progression pathways. One that we call papillary and that we call non-papillary. These are pathologist designated words. So the papillary pathway is the kind of cancer that looks like a mushroom growing into the bladder. It's got a stalk and it looks like a broccoli or a mushroom.
Cauliflower all the time.
Yeah, cauliflower. Yeah. Whereas the non-papillary, this would be the kind of lesion you'd see in a patient with CIS, something flat. And it does appear that these two pathways are very different and that progression to muscle invasion is much more frequent in the non-papillary pathway.
Interesting.
Now, with that said, we do know that some mutations are more commonly associated with invasion and progression, including this gene P53 that many people may have heard of already. But when it's mutated, it seems to help promote this.
Dave, next question. On the cytology question, do you mean that the rate of false negative results is high, even in presence
Yes.
of high-grade disease? Is it more sensitive for CIS? So we're talking
It
about
is.
false negative results.
Yes. Yeah. So it's a sampling issue, as usual. You have to have cancer material, in this case, cancer cells present in the test. At AUA, we saw a group from Karolinska really get serious about this. They do barbitage. They inject fluid into the area of, in this case, the upper tract that's suspicious for disease. And they can pull out a lot more cancer cells that way. So in theory, you could have a higher sensitivity with cytology if you did something like this. But the advantage of the liquid biopsy, as we've been talking about, is that the DNA from the tumor is, it seems, more often present in the liquid part and not in the cells. So the DNA is outside the cells. And so we can see the cancer and detect the volume of cancer better because we're measuring the tumor both in the liquid part and also in the cells. It's both compartments.
This is my dumb question. If you had same patient, same situation, you had a urine cytology, liquid biopsy, and you had a blood, would they read the same?
No. So what we've seen so far, and Roger Lee's done some of this work at Moffitt with the Predison assay, is that the urine tends to measure out disease that's in the bladder, whereas the blood tends to be less good at that, inferior. So what we're probably getting in the blood is, in some cases, muscle invasive bladder cancer that's still in the bladder. But certainly it's enriched for metastatic disease.
I see.
Yeah.
Mr. and Miss Burnell is asking when will liquid biopsy replace yearly imaging tests to look for cancer recurrence?
We're talking about distant recurrence. I think when we're talking about imaging, typically it's either MRI and other approaches for the bladder, and then PET and CT for distant disease. I think that we're probably not going to see replacement. I think we're going to see augmentation. I think the next step in this is going to be to use the conventional approaches we already have and the conventional surveillance strategies we already have. So the same timing and everything, but augmented with liquid biopsies. I was at a meeting in Europe where I heard an AI enthusiast who runs the biggest AI company over there tell everyone in the audience that he was going to replace all of us with AI and machine learning. And it became a joke for the rest of the meeting. I don't think we're going to be throwing out radiologists or pathologists anytime soon, or for that matter, cystoscopy. Rather, what we're going to see is a transition to time when we're going to be using both. And I think as a consequence of that, we'll be seeing head-to-head comparisons of how easy it is to detect cancer with both.
There is a question about repeating the names of the companies offering the urine biomarkers.
So the two that are already in this space and have received the most attention are Convergent Genomics and Predicine, which is like medicine, but it's Predicine. And our friend Deb Sunday at Ohio State is among the leadership in the Convergent Genomics efforts. And our friend and colleague Roger Lee, who is at Moffitt, is among the leaders in the Predicine efforts. And Natera is moving in too. So they're going to develop another personalized assay for patients with bladder cancer. So I suspect we're going to see a lot more activity in this space going forward. So the Convergent relationship goes back to about 2012, 2013, 2014. One of the urologists in the Southwest Oncology Group was working with one of the founders of this company, Joe Gray, who's also, by the way, the guy who invented FISH, which is the technique for Eurovision. And so we've had a longstanding kind of relationship with those people through the Southwest Oncology Group, which is partly why we know the most about their platform. But I suspect, just like I said earlier with the plasma assays, the blood assays, that there are going to be a lot of good assays available pretty soon.
So Convergent and
Predicine.
And by the way, the physicians you mentioned are like top recognized bladder cancer experts. And that's really nice. That's very comforting to know that they know the disease and they're working on this. So,
exactly.
Do you know of any clinical trials at Hopkins or elsewhere looking at liquid biopsies that patients can get involved in?
Yes. So the liquid biopsy trials right now are focused on blood. So these are for patients who've already received cisplatin chemotherapy, or they were ineligible for cisplatin chemotherapy. They had cystectomy, and now these clinical trials are looking at whether or not we can identify the patients who need adjuvant immunotherapy by measuring tumor DNA in the blood. So far, we don't have a clinical trial with urine tumor DNA, but Scott Delacroix is trying to design one. I think Stephanie knows about this trial through her role in the task force. We're trying to find a home for it because in the Southwest Oncology Group, we've had a wealth of bladder cancer trials, and I think the prostate and renal folks think it's their turn to propose new trials, but there's still a lot of enthusiasm for Scott's trial. We discussed it in the clinical trials planning meetings, and I think that we're going to see bladder retention trials, the Retain 2, Retain 3 trials that are led by Fox Chase. I suspect we're going to see a lot more of these bladder sparing retention trials opening that involve tumor DNA measurements in the urine. We're going to be doing them as a part of our renal retention trial led by Jeannie Hoffman Census in patients with upper tract cancer. It's not open yet, but we'll be measuring tumor DNA probably using a Convergent platform in patients who are receiving pembrolizumab and enfortumab vedotin for renal preservation.
We have a few more questions. We might not get to them all, but we are happy to answer them. So bladder cancer.
We'll save them up and we'll send you written answers. Yeah.
And this is Katie again, and I think we've already answered that, but one more time. Is blood liquid biopsy better for ruling out metastatic disease versus urine?
Yes.
Blood is better for metastatic than
correct.
Urine. Okay.
Yes.
And the last question, Mr. Brunel or Ms. Brunel, if you had a cystectomy, will the urine test still be effective in detecting follow-on cancer that imaging tests are looking for? So we can just answer that. So
the thing about urothelial cancer, as many of you know, is that having upper tract puts you at higher risk for bladder cancer, and also to a certain extent vice versa. So if you have your bladder out, you're still potentially at risk for an upper tract cancer. And so there is some value in measuring tumor DNA in the urine, even in patients who've had a cystectomy. The problem with our imaging tests like PET is that all the dye that we use to see things comes out through the kidney. So the kidney and the bladder look lit up with PET imaging. It's hard to see things in the bladder, the urothelium. So I think that there will still be a role, but obviously the more important concern is for metastatic recurrence. And so a blood test at that point is probably a more important surveillance tool if you've had a cystectomy.
So I have a housekeeping request. So those of you who still have questions that we haven't answered adequately or enough, please email us, because I think the questions go away when we tune out and we want to answer them properly. So bladdercancer@jhmi.edu, and we will answer. Dr. M. McConkey will do. And this is a really important final question because it's sort of a profound question. Let me see where if I can find it. All right, David McConkey, you're on the spot. The anonymous attendee asked, did I hear correctly that tumors that shed a lot of cells tend to be more aggressive?
Tumors that shed a lot of DNA tend to be more aggressive. And the reason we think this is the case is that tumors that divide and increase in number quickly are dying more by a physiologic programmed cell death. And that's how we think the DNA gets released. So higher grade tumors tend to release more DNA.
Got it.
Yep.
Well, it's 5 o'clock. This has been illuminating and really hopeful. I mean, there is a day when this will be a screening tool and we'll look back, hopefully not too far, say, what was the big deal? We should have had a screening tool for bladder cancer all along. That's what's maddening about this disease, is like you can't screen for it like you can for other cancers, but it's coming and it's hopeful. And in the sort of landscape that I'm like a teeny part of, there are trials now that they're creating that include biomarkers for the first time. Dr. McConkey's a leader in that role. Sorry to toot your own horn there. And also bladder preservation trials, which when you think about it, is a hard trial to figure out how to do so that no one's harmed. We're going to preserve your bladder if you get XYZ, or, it's very complicated, but that is in the mission in many cases, is to not overdo it. See what's available. There are a lot of new tools in the toolbox. When we started this thing, there were no CX bladder tests. There were no tests at all. There was no biomarkers. There was no David McConkey. It's come a long, long way. And in 7 years, there's like 8 or 9 new drugs that didn't exist. So stay with us on the journey. And you never know, it's getting better every day. Thank you, David, for your leadership, for your work, he's always in the lab. You can't believe what he does all day long. It's amazing. And, even though bladder cancer is awful and we're here for you, please send us your questions. There's a lot of progress being made. So I hope you walk away knowing that that's the case. Thank you all. And next week, you can ask the same questions of our star oncologist, clinical trial expert, and very well skilled in this topic, Dr. Noah Hahn. It's office hours. He's just going to ask any question you want to give him. No slides, nothing. Just ask Noah. That's what it's called. And that, I believe, is next week. It's a novel thing that we're doing. We haven't really done it before, but he's a fountain of knowledge in bladder cancer. So if you have a question we didn't answer adequately, I certainly can't answer them. Ask Noah next week. And hopefully, if you like that program, we'll continue it because we're excited to offer that. And then not to forget, we are now creating special programming for our upper tract patients because we realize that they, upper tract disease is its own thing, and that you deserve as much attention as everybody else. So we're expanding our upper tract programs, and there will be now upper tract programs like this just for upper tract. So stay with us, and we'll see you next time. Thank you, everybody.
Thank you so much, everybody. Great questions. We'll do this again soon. Yeah.